Chapter 9, we are going to be learning about drug handling and how drugs are packaged, and then how and whose responsibility it is to handle them inside of the OR. So our learning objectives, there are what are called 6 rights of medication administration. We're going to talk about how they're verified, where they're stored within the hospital. So there are 3 places, kind of systems to get drugs. What an EMR is, the various packagings that are available for drugs, the information that's required to be on the label and like the package insert, how then in the next half of chapter 9 we'll talk more about the handling supplies, the Needle Stick Act, the roles of the surge tech and the circulator with the drug transfers, how to label everything in the sterile field, and then the different ways of transferring drugs to a sterile field. So the safe medication practices include these 6 rights of medication administration. So the first one is making sure we have the right patient. And most of these are common sense. So we want to make sure we're giving the drug to the right person. We are giving the right drug to the right person. We have the right dose. So again, that math part and understanding how to calculate the dosage properly, and that's actually what's being administered. The right route of administration. So ensuring whether it's given intravenously or inhalation or whatever the route is, that it's the correct way. The right time and frequency. So how often does it need to be given and at what time? And very important is the right documentation and labeling. So everything has to be labeled and everything has to be documented. All right, so if we look a little bit more at the right patient, again, this is going to identify the patient pre-op holding and in the OR. Patients sometimes get frustrated because you're asking them their name, usually in date of birth as well, multiple times, but that's just part of making sure that the right patient is getting the right surgery or the right procedure, the right medication for whatever's happening. Also, they're going to note any allergies. That's, again, something they get tired of repeating, but again, going over those lists of allergies. As far as the right drug, this is where those surgeon preference cards come in, where they kind of prep what should be ready to go, or especially in the OR, those verbal orders are okay as well. The drug is going to be verified 3 times. We'll talk more about that drug verification in just a little bit. The right dose, so making sure that it's understood, especially if it's verbal, not only that it's the right drug that's being used, but what dose is being asked for, and then calculating that properly. I'm reconstituting it. So again, that's if something is a solid and we need to turn it into a liquid. So we need to add water or something, some kind of liquid to it, then we're adding the right amount. And then also that makes sense, that it's consistent with their age, their size, the diagnosis, and the gender. So that's why you have to learn some of these drugs that we'll talk about in chapter 10, is so that it makes sense. Oh yeah, I know this is for high blood pressure, and this is kind of what's going on, so that things, that you can kind of check and ask questions like, is that right? Again, just making sure that everything is done correctly. Again, right route of administration. Again, making sure it's right for surgery. We're typically not going to be giving anything orally. So again, just making sure that everything makes sense. Time and frequency, less applicable in the OR because usually drugs are only given once. They're not usually in surgery long enough to repeat that, but sometimes that may be the case. Again, documentation and labeling. Everything has to have the name of the drug, also the dose, the route of administration, documenting what time the medication was given, and then any kind of unusual response. All of that gets documented for the patient. And then everything also is documented right away after administration, but never before. So if the surgeon says, I need 5 milliliters of morphine or something, you only document that after it's been given, because you never know. Like maybe you've drawn it up, you're getting ready to give it, you document it, just getting ahead of the game, but then something happens and you don't end up giving it. So you only document after something has been given. And then also all the storage locations are labeled. So if you are taking something from a vial and putting it into the syringe and then into the patient, that syringe has to be labeled as well. All right, so the 3 verifications, making sure that the right drug is given. The first verification is during the removal from storage or when checking items on the procedure cart for accuracy. So if we're already in the OR, so essentially the first time we're picking up the medication, that's the first time that we're going to verify. The second verification is just before you remove it from the container. So whenever you pick it up off the cart, you're going to verify it. If you were, placing it, into a syringe just before you start drawing it up the syringe, you would verify the drug. And then the third is immediately after removing it from the container. So from the storage or from the cart, right before you take it out of the container, and then right after you take it out. So transferring to that sterile field requires 2 individuals, and we will talk at the end of Chapter 9 about those roles. So we have the circulator and the surge tech, and both of these individuals will be involved in these 3 verifications. Now, what are you verifying? So obviously the name of the drug, but also the strength of the drug and the expiration date. So all 3 of those are verified each time we go through one of those verifications. So if the drug's passed to another surgical team member, that drug information is verbalized again as the drug is transferred and each time after that. So if we're handing it from one person to the next, every time we're transferring it, they're going to say the name of the drug, the strength, and the expiration date. It can get very repetitive, but it ensures that, again, we have the right drug, the right dose for the right patient. Now, the 3 drug dispensing systems, just places that we find medications in the hospital. So the hospital pharmacy is going to have the largest supply. We also have satellite pharmacies, so like a drug cart, for example, where that is either like on a floor or in the OR or just right outside of the OR. That satellite pharmacy is there. It's going to have a larger, a larger system selection of different drugs, but not nearly what a hospital would. So they're typically more kind of common to that. So if you have a cardiac floor, or a cancer floor, the drugs in those satellite pharmacies would kind of match the common symptoms or the common conditions for patients on those floors or in that place. And then we also have automated dispensing systems, which is what the picture is showing, to where it's almost like a vending machine, but for medication. So looking at the hospital pharmacy, this is usually open 24/7 with 1 or more pharmacists that's on staff. Their responsibilities are just making sure that everything is ordered and maintained, kind of stocked properly. We're not running out of medications. They actually prepare some of the fluids for infusions, especially, again, like chemo. The compounds, so they can kind of mix up the different drugs. They are the ones in charge of controlled substances. So if there is an issue with kind of improper use or knowing where and how much of the controlled substance there is, it's the pharmacist who's responsible for that. They create the patient charges, they dispense the drugs, implement and enforce the safe drug handling and administration. So access is limited, here, so not everyone can just walk in and pick up something. Again, the pharmacist is kind of handing those out, or there's somebody else there giving you the drugs that have been prescribed. So usually there's like a service window or something, or they're delivered to the patient care area. Now the satellite pharmacy, so like one in the OR is an example. Again, some nursing floors and stuff like that can also have these. But this is more convenient. They don't have to go to the pharmacy for this. They're a little bit more accessible. Just anyone can kind of, access those. They serve the medications that needs in surgery. So again, we're not going to have every drug that would be down in the hospital pharmacy, but those common to surgeries. And then this can provide drugs for like pre-op holding as well. So like post-anesthesia care, and even sometimes can be in the endoscopy suite. So some of the options, again, we have limited access because again, it's not big enough. It's not like the pharmacy, so we don't have quite as much available. And then it's staffed by the pharmacy personnel. They're the ones that are restocking that. So again, it's more accessible, but it does have to be stocked by the pharmacy. Then the automated dispensing system. These can be available throughout the hospital setting. Again, they're stocked with medicines, also sometimes supplies even that are commonly used in the area. Again, staff are granted varying access. So again, someone who shouldn't be, administering certain drugs wouldn't have access to be able to do that. Obviously, public wouldn't have access to be able to withdraw medications or supplies. So this also provides a method for inventory control. So it's automated, so it's easier for the pharmacist to keep track of what has or has not been used. Also charging the patient, so as far as that documentation, that patient code is put in with whenever it's withdrawn, so it automatically updates their chart and that documentation, and it is a little bit easier to track those controlled substances. Now it's unopened, any unopened non-narcotics, so again, not scheduled like controlled substances, but if they're unopened, those can usually be returned to the machine and then the charges are removed from the patient's bill. Now, controlled substances cannot do that. They have to go back to the pharmacy. So the unopened, unused narcotics, though, again, go to that pharmacy. And this can provide access to more than one type of medication or supply. All right. As far as our record keeping and documentation, there's what's called the EMAR, which stands for Electronic Medication Administration Record Keeping System. And this just uses a barcode. So you can see the barcode on this medication here. So that can just be scanned, and this just makes it a lot easier for all the healthcare professionals to document, so they can scan that and it automatically goes into their chart. So the benefits, again, it decreases human error, so we're not typing things in, it's automated. It helps to identify the drug interactions and contraindications. So again, if the chart, again, because it's going directly into a patient's chart, that chart knows what medication is already taking, so it can help identify any issues. It can also propose a dosing schedule, so how often should they be getting it, just to kind of, again, double check with what the prescription may be. And it alerts for allergies. Again, this is tied to the patient, so if they're allergic to penicillin and penicillin is being prescribed, it would help alert to that. So again, it's a reduced cost alternative. Kind of some follow-up lab screenings can give those. So like, oh, hey, make sure we check the blood every 24 hours for this if they're on this medication. So it just really helps to alert and kind of check what's being given. Now, what are some of the packaging supplies that are used, especially in surgery? So most in the surgery are for single patient. So they're going to be in smaller packages instead of like a big bottle or something or a big vial. It would be small amounts. And leftovers are typically discarded because, again, we're talking about sterile fields, so it's harder to reuse supplies. So some of these packaging supplies, and we'll go through the laundry list and then we'll touch on what each of those are. So ampules, cylinders, so we think about like our gases stored in those, preloaded syringes, so it comes already with the drug in it. We have tubes, we have vials is the main thing we think about when giving medications because we think about IVs. They can come in packets, solution bags like IVs or antibiotics that are going through the IV, a solution bottle. So our ampules, if we start there, so the picture over here to the right is what our ampules look like. So these are small because, again, in surgery, we're using small amounts, kind of single doses. So it's heat sealed that makes them airtight or hermetic. And the neck is actually scored, just meaning there's kind of like a small line that's going across them, but that just kind of gives a nice place to break that glass to open it. Sometimes they're tinted, and that just helps if there's a chemical reaction with sunlight that would break down the molecule. It's stored in a darker container. And this ensures whenever you're using this, you want to ensure kind of tap it and make sure that all the solution is in the bottom, because you don't want it to be up here in the neck, because that's where you're going to be breaking it. Wherever that score is, you're going to break it. So you don't want the solution to come out of there. You want everything in the bottom. Whenever you do this, you also want to push your hands away from the body instead of towards you, just to prevent glass from potentially coming at you or cutting you. And typically, because of the little glass shards, whenever this is being removed, what's called a filter needle, and we'll talk more about the types of equipment that's used to transfer it in the next session. But a filter needle, so it's drawn up, so it would remove any kind of pieces of glass that may be in there. Cylinders, so again, this would be our gases and how they're stored, because again, they need to be pressurized to bring it back to a liquid for storage. Then they're put back into their gaseous form to actually be administered. So oxygen goes in here, even though it's not technically a drug because we need it in everyday life. But NO, which is nitric oxide, these are usually piped in. So like in the hospital room, you'll have like your different colors that go along, because it's, instead of having a tank in the room for oxygen and one for nitric oxide, instead there's kind of a central location for these, and it gets piped throughout. Now the outlets again are color coded, and the connectors are not interchangeable, so you can't connect, like the nitric oxide connector wouldn't fit into the one for oxygen. Just helps prevent getting those mixed up. And then there's a regulator valve or something to control the release of the gas into that from that cylinder. All right, our preloaded syringe. So again, we think about a syringe, and normally you're drawing solution up. Preloaded just means that the manufacturer has already put the drug in it. So it has that pre-measured dose that is already there. So again, some common drugs that are used are common dosages. Then sometimes these preloaded syringes are used. So they have a sterile hypodermic needle that is attached to them to keep that sterile process and field intact. Also, just kind of some terminology here, the cartridges are also called carpels. So you may hear those, typically cartridges used, but carpels is another term for that. So the barrel part of the syringe is inserted into the reusable holder at the time of use. And then they may have the sterile hypodermic needle already attached, or you may have to attach a sterile needle to it. All right, so our tubes would have our semi-solid, so like a lotion or some type of gel. So these are typically sealed with foil or plastic or something, just to, again, make sure that everything inside is sterile. So never use, if there is a CO and something has been punctured or it's broken in some way, because again, at that point, we would no longer consider it sterile. Now the outer cap of those is not considered sterile. And a lot of times it has kind of a pointed piercing mechanism, so you can puncture that seal. Again, cap is not really considered sterile. So the non-sterile team member discards just a little bit of it before placing the needed amount in the sterile field. And that's just in case there was any kind of contamination with the air or anything during the opening process. By removing a little bit of it and discarding that, that's what would have been exposed. So then everything inside would be sterile. Our vials, again, this is commonly what you think of. So these are plastic or glass. Usually has a solution or a powder. So if it's powder, it needs to be reconstituted. We need to add that liquid to it. It's sealed with a sterile stopper that is called the septum. So this is usually gray, not always, but it just kind of covers the opening. And then it's held by the aluminum collar, and you can see on this vial here, you can't really see the septum because the aluminum collar is covering it up. And then that plastic cap sometimes is attached as well, just to, again, just another layer of protection. 3 different ways to remove the contents from the vial. One is probably the most common, is inserting the needle through that rubber stopper or that septum. So you just remove the cap without touching the sterile stopper, disinfect that with an alcohol swab, and then just puncture the needle of the syringe into the stopper and withdraw the solution. You can also use what's called a transfer device. So again, we're removing the cap without touching the septum or the stopper, disinfecting with the alcohol swab, same as the other one, but now we're using a sterile transfer device to convey the contents to a syringe or to a container. And then finally, you can also pour the contents out. So this is the only one that actually removes the cap, the collar, and the septum or stopper. So then the medication is then poured into a separate container. Now the importance here is to protect the integrity of the label when pouring. So you're actually going to put the label, like the important stuff, what is written, into the palm of your hand. So as you're pouring it, the solution isn't dripping down over what that label has on it. Is going to be a packet. So this is just a miniature envelope. I'm sure you've seen like at gas stations too. They have like a little single use, like ibuprofen or something like that. So these are just miniature envelopes that have a small amount, usually again like a single dose that is sterile. The packet is usually made up of foil, plastic, can be paper though as well. And one end usually is notched or kind of peeled apart. You can kind of see on this one here. And that just makes it easier to open. And it's the job of the non-sterile team member to actually open the packet and then express the sterile contents into the sterile field or to the sterile team member. Solution bags, so these are like IV bags that are made up of PVC or vinyl. So those sterile fluids that are being used for injections, infusions, or irrigations are contained in these. Sometimes a glass bottle is needed if the solution could be degraded by the bag. So again, if it reacts with that PVC, then we need to switch to a glass bottle. Or if the drug is actually kind of breaking down the plastic or leaching it, we don't want the plastic getting into the patient, so then a glass bottle would be used instead. The protective cover and cap are removed before we use those. And then it's attached to what's called the administration set or a transfer device to actually get it into the patient. Now, the higher the bag is placed, so if we think about like an IV stand and you're placing the solution, the higher up it is, the faster it's actually going to drain. All right, now what is this administration set that's used to actually get the contents out? So this is also called IV tubing or an infusion set. And this just allows a sterile pathway for that fluid from the IV into the patient. So the outside tubing is not considered sterile, but the inside of the tube is sterile. So those IV bags use non-vented admin sets that collapse. So then they, again, as the contents decrease, the bag decreases. It's not keeping a bunch of air in it. The glass bottles have to be vented to displace the air because obviously they can't collapse. And then what's called spiking, which is adding, actually inserting a needle or something into that bag to get the solutions out. And then we connect it to the admin port. So both, again, are sterile and have that protective cap that needs to be removed. So then how does this happen? So they have a roller clamp on the admin set. You want to make sure that's closed before you insert the spike into that administration port. Once it is attached, you're going to let that roller clamp out a little bit until the drip chamber is filled to half full. Now again, it's important that it is at half full, because if it's all the way up, you can't monitor the rate. And that's what the drip chamber is for. It allows that monitoring of the rate by counting the number of drips per minute. Helps determine the rate if it's not digitized. That's how you can determine that, is watching the drips per minute. This also prevents air from entering into the tube. Then that roller clamp is slowly released to what's called prime the set, which is just filling the set with the solution. So this may invert injection ports to prevent air bubbles. And then we close the roller clamp once the solution is at the end of the set and is now ready to connect to the IV catheter of the patient. Now, anesthesia providers or circulators determine what that flow rate is. So again, you can monitor it if it's not digitized by counting the drips, but the actual knowing what the rate should be is based on what the anesthesia sets. And those nursing personnel in pre-op and post-op areas are going to be watching over that. This is just showing what the transfer devices look like. So it has a rigid spout that's attached to the vial or the solution bag, and then we remove that protective cap and transfer the solution to another vial. So not actually into a patient, but we're using it to transfer it into another sterile container, like a solution bag or some type of container. So again, typically that basic admin set is used. Now the solution bottle, again, this is kind of a firm plastic container that won't leach or allow the contents to vaporize. It is double sealed, so it's not used though if that seal is broken. For use, mainly in the OR, is for irrigation, so flushing out a wound or an opening and an incision to flush that out. Now there are two different ways to get the solution out. So the outer seal is removed and vented. That vented irrigation set's attached by piercing the seal with the spike end. And then both the outer and inner seals are removed and the solution is then poured into the container. So again, we can either attach it using that spike end, or we can just pour the contents out. And then finally for this one, just looking at how to pour from the bottle. As I mentioned earlier with the vial, to maintain the integrity of the label is put in the palm of your hand, so it's away from the lip so that it's not dripping solution down over the side onto the label. So the lip is the only thing considered sterile and able to be in the sterile field. So there's a minimum 12 inches between the lip and the container. And you never are going to recap the bottle because, again, that cap is not sterile. So you don't want to add the possibility of it like transferring germs to occur. And then you need to have some of them had this ring on the bottom for index or the middle finger to prevent dropping. So just to prevent you from dropping them, they have an extra ring there, and that just helps to hold on to it.